welcome to everyone joining us this morning for this session of Commonwealth North's Healthcare Reform Study Group. I first want to thank Providence Healthcare and the Rasmussen Foundation for generously providing support for the series that we're running this spring and summer on chronic disease management. For those of you who've been with us over 2 or 3 of these sessions, you know that on April 14th, we heard from the Alaska Division of Behavioral Health on the 1115 waiver that allows for new responses, approaches to behavioral health crisis response. And this morning, we'll hear from the Alaska Mental Health Trust Authority and its partners on their work in developing and scaling up the Crisis Now model for Alaska. Crisis Now is a roadmap for safe, effective crisis care. It diverts people in distress from the emergency department and incarceration by developing a continuum of services. By redirecting those in crisis to more effective and less expensive settings, the anticipated outcomes include prevented suicides and providing more immediate and targeted help for a person in distress. It also reduces the costs of care by reducing the needs for psychiatric hospital bed usage, emergency department visits, and law enforcement. That is information provided by the National Association of State Mental Health Program Directors. With the help of the Alaska Mental Health Trust, we've invited a panel this morning representing various partners who are working to implement the Crisis Now model. Our panel today includes 5 individuals. Steve Williams, the CEO of the Alaska Mental Health Trust Authority. Steve will provide an overview of efforts to transform Alaska's behavioral health crisis response and also the Crisis Now model. Prior to assuming the CEO role earlier this year, Steve had served as the Trust Chief Operating Officer for 8 of his 16 years with the Trust. As CEO, Steve oversees the Trust Authority as well as the Trust Land Office. Also joining us are Mike Sanders and Barbara McFarland from the City of Fairbanks. Mike serves as the Chief of Staff in the Mayor's Office. Mike joined the city in March of 2017 as Housing and Homelessness Coordinator. He excels in project management and bringing agencies together. He brought that experience to the Crisis Now implementation in Fairbanks. Brenda is the Crisis Now Coordinator. She has experience working with families and individuals struggling with homelessness and access to healthcare, including behavioral health care. Together, they'll describe how Fairbanks has developed and implemented mobile crisis teams. From the Department of Behavioral Health for Providence Health Services, Renee Rafferty, the Regional Director. She has been working in behavioral health for 30 years. Joining Renee is Melissa Merrick, Clinical Director of Behavioral Health Services for Southcentral Foundation. She plays a key role in overseeing behavioral health clinical quality and improvement activities for Southcentral. Her experience providing behavioral health in multiple clinic settings has given her a broad view of ways to address behavioral health needs across the continuum of care. Renee and Melissa will report on their efforts to align and integrate crisis stabilization services. We'll wrap up today with a moderated Q&A. Please feel free to submit questions in the chat window at any time. So now it's my pleasure to turn the virtual floor over to Steve Williams. Steve, if you want to open your mic and begin.
Thanks, Ralph, and thanks to you and Winetta for holding this conversation. It's a great topic, and hopefully we'll be building on the excitement that was generated from the conversation folks had with the department and the Division of Behavioral Health last week. My name is Steve Williams. I'm the CEO for the Alaska Mental Health Trust. I'm privileged to be on this panel with our partners from Southcentral Foundation, Providence, and the City of Fairbanks, 3 key partners in this effort to transform Alaska's response to behavioral health crisis. And that's not to not acknowledge many of the folks who are probably joining this morning's call and conversation that are also a part of this effort. As you'll hear, this is an effort to transform a system, and in order to do that, there needs to be, and there is currently, a collective effort to do that and have a unified way to approach a person in a behavioral health crisis. Next slide. And maybe the next one, Renata. Great, thank you. So the goal here is to explain how we are going to transform our current system. Our current system, as folks may know, is not a good system for the individual in crisis, nor is it the appropriate response mechanisms from our system as a whole. We currently have a system that relies on law enforcement and other emergency medical first responders to a person in the community who's in a behavioral health crisis. And once they're there, their tools are one of two things generally. They can do their best with the skills and tools that they have to try and de-escalate the situation and keep the person and the community safe. And if they're not able to do that, they have only limited options to take someone to a designated evaluation and treatment facility. There are only 4 of those in the state, and you can see those listed on the screen. Or if the capacity is full, hospital emergency rooms. And then the last resort, which is used as a last resort, are the Department of Corrections, our correctional facilities. None of these options are optimal, and none of them are the best use or the purpose for how those options are intended to be used. So we really took advantage of a situation, a crisis in 2018, when the Department of Health and Social Services was sued by the Disability Law Center and the Public Defender Agency because there was limited access for people with acute behavioral health crisis, and said, this is the time to reform the system. There will be no other time. Next slide, please. So we all know what to do when we see someone in the community maybe collapse in a grocery store. Maybe we have a family member who gets in a car accident. We injure ourselves and no one's around to help us. We know to call 3 digits, 911. We know what to expect from the person on the other line, and we expect some sort of response to be dispatched to the situation, where trained professionals will assess the situation, treat the situation, and then refer the person to the next level of care if needed. What we are trying to do is design a system analogous to that for someone in a behavioral health crisis. So if a family member or an individual calls, they can expect to have someone on the other line that is trained in mental health, might be able to triage the situation and resolve it on the phone. If not, be able to dispatch a mobile crisis team, which is a component of the Crisis Now framework that we are using to transform the system. If they can't resolve the situation safely in the community, or the person needs a higher level of care, where there is capacity and the ability to stand up 23 crisis stabilization centers, a person could be transported there. And then if they need a longer term stay beyond 24 hours, short-term stabilization up to 7 days is a possibility. What you see here is building out the middle section of our continuum of care. As I mentioned before, our continuum of care exists with law enforcement and other first responders on one end, and then API and the other 3 DET facilities on the other end, and there is really nothing in between. And so our system is designed to take people to the highest level of care, whether or not they need it. And that is just not a good use of resources. It's not good for the individual. It can create unnecessary trauma, and it can prevent them from staying in the community when they can. Next slide, please. So the Crisis Now framework, this is what we are looking to do. And I want to, if you guys remember a catchphrase from this, it's the phrase at the top of the slide here. If someone asks you about what the Crisis Now framework is, it's someone to talk to, it's someone to respond, and a place to go. And that's what we are hoping to do with this transformation. Again, this screen illustrates sort of the components of the model. And I just want to also underscore that this is a best practice from SAMHSA's guidelines, as well as from suicide prevention, for safety, as well as from a trauma-informed approach. Next slide, please. So I mentioned the lawsuit in 2018, and soon thereafter, the trust and others convened stakeholders, and it was actually held, I believe, on Southcentral Foundation's campus, to take a look at what the system is from a variety of perspectives, from providers, from first responders, from law enforcement, from patient advocates, and really have a dialogue on how we could do this. It was informed by a couple of studies that had been done, one by ASHNA and one by the Division of Behavioral Health, to look at different pieces of the psychiatric crisis continuum, and then take that information to develop a unified solution, and a solution that could inform policy and the direction for transforming the system, so that Alaskans actually are able to access the level of care in the appropriate level of care in a crisis situation, instead of what the current system, how the current system was operating or responding. So when we had this conversation, when we looked at these studies, we started looking around the country to see how other states and communities had systems set up to respond to someone in a behavioral health crisis. And we kind of locked in on Maricopa County in Arizona, who had a no wrong door approach, who had taken several years to develop this framework, so that individuals were being in a crisis were being met at their place and directed to the right level of care. The model down there has a no wrong door approach. And what I mean by that is that the 23-hour crisis stabilization center will take anyone, whether they walk in voluntarily, whether a family member brings someone, whether they're there on a protective custody hold or an involuntary status, whether they're there because of a psychiatric crisis that may have some other substance on board, someone with a co-occurring disorder. They say, bring them in, we'll assess the situation, we'll use our trained medical staff, mental health staff, and peers to help address the situation and get the person the treatment and the care they need. So that is what the no wrong door approach is. I'm going to speak a little bit about some legislation that's going through the Capitol right now that will effectuate this no wrong door approach. Next slide, please. So I mentioned this has been a collaborative effort, and it's the effort to transform any system really does require participation, support, and everyone rowing in the right direction. Understanding what the problem is, understanding the vision for the solution, and understanding their roles and abilities to help create a new system. And so this slide is just illustrating for you the work that has been done, and these numbers continue to get updated because these work group meetings, these conversations with communities, these partnerships develop over time. This is a living, transformative process that is going to take a couple of years before we get it fully stood up with all the components and moving in a smooth way. And you can see down at the bottom of the screen an illustration of the funding that our Board of Trustees has approved towards this effort. Next slide, please. So as a part of this planning effort, I mentioned Maricopa County and Arizona. The trust contracted with the operator down there, RI International, to come up to Alaska, focus in on Fairbanks, Anchorage, and the Mat-Su Valley as core communities for change, and really look at the impacts and the responses of someone in a behavioral health crisis in those communities, see what the assets and the gaps were in the service system in those communities, and then develop a plan for right-sizing the components of the model for the communities based on population, the data that showed persons in behavioral health crisis, and where they, from their experience, see how those numbers could be pushed into the different levels of care that have been described. So that RI report, which is on the Trust website, helps to ground the effort and to make sure that as we move forward, we were moving forward not just with a framework in mind, but with the data to be able to stand up the framework in a way that would lead to success. Next slide, please. So this is the full sort of model, and it's a flow chart and a graphic that I've used in legislative presentations that illustrates the continuum of care as envisioned. And I just want to underscore here that, you can see a very linear path here. The path for someone in a behavioral health crisis doesn't have to be linear. They don't have to start with the mobile crisis team, go to or start with a call center, go to mobile crisis, go to 23-hour, go to short-term stabilization before getting to API. There will be opportunities depending on this person's situation and the medical and mental health professional assessments for people to move through this or access different points of this when appropriate. I think it's also important to note that not every community has the capacity or the demand to stand up this full continuum of care. However, the model, as it's illustrated here, does provide communities the opportunity to assess their current system and figure out which pieces might be able to be added to augment their current system to create better outcomes for individuals. You'll notice that law enforcement and other emergency responders are a part of this flow. We are not trying to suggest that they're not part of the solution or a part of the tools that can help someone in a behavioral health crisis, but they shouldn't be the default responder. It should be a crisis care line. It should be a mobile crisis team that is the default response. And you also will note that emergency hospitals and other locations are a part of this. Again, they're a part of the system, but should not be the default response or the default place for someone in a behavioral health crisis. The last thing at the bottom of the screen, the 1115 waiver. I'm not going to go into this because I'm assuming that the folks from the Division of Behavioral Health did this, but it is a foundational funding mechanism for this system of care. It's not going to be the only funding mechanism for this system of care, but it is foundational, and then other revenues from other sources will have to be braided in to fund the full continuum of care. Next slide, please. This is just an illustration of the trust investments since FY21 and it's sort of where those investments have gone to date. I just also want to note that this is just the trust, but our partners, some on this panel, some of you may be watching this presentation, have also contributed either financially with staff or with other resources to help in this effort. What you don't see on this slide is that there is roughly an additional $5 million that our Board of Trustees has allocated for the upcoming state fiscal year that begins July 21. The trust and our partners and all of you recognize that this transformational process is going to take several years, and our Board of Trustees has committed to this effort for several years. They understand the horizon isn't immediate, but as long as there is a plan and a vision, we can move through it in a way that gets us to the end goal as soon as possible. Next slide, please. So I mentioned the no wrong door approach earlier, and I highlighted SB 124 and HB 172. These are pieces of legislation that are currently working through the legislative process. HB 172 actually has a hearing this morning at 9 o'clock in House Finance. SB 124, there was a hearing yesterday in Senate Judiciary. These bills are critical for being able to have a no wrong door approach. They are bills that allow for facilities operated and designated by the department and operated by partners to be able to accept someone in a behavioral health crisis in a protective custody status or in an involuntary status. Right now, the only places that can happen is at API or the three DETs, the Bartlett and Juneau, Matsu Regional, and Fairbanks Memorial. In order to be able to use lower levels of care, that 23-hour crisis stabilization or the short-term residential facility, we want to make sure that those facilities have the tools to be accepting anyone, to be able to use their professional staff to assess the situation and then direct the right level of treatment. Without this bill, 23-hour crisis stabilization, short-term residential services will only be able to accept people in a voluntary status. And that's not to say that that's not a need, but it is not the full need. And there are people who are going to be, whose crisis is so acute that they may need to be taken to one of those facilities. Next slide. So just sort of some key takeaways about the bill as an educational proposition. I'm not going to read through these things, but I would really encourage folks to take a look at the legislation, pay attention to the bottom half of this slide of what the bill does not do. There's been a lot of questions and people wanting to alleviate concern that this bill doesn't interfere with a law enforcement officer's ability or authority to make an arrest. It does not. It doesn't change the current statutory framework for who and how to administer and when crisis medications can be administered. Again, it's absolutely paramount that this legislation get passed this year so that when we stand up these other service types, that they will be able to follow the no wrong door approach. Next slide, please. These are just sort of the bullets of where we stand right now and where we're moving with our partners at the department and with our community partners. I will just say this level of effort, this level of collaborative focus and desire to change the system, in my opinion, is just really inspiring from a systems perspective. But most importantly, because the systems and the players involved recognize that we can be doing so much more for individuals in a behavioral health crisis. They're just not getting their needs met the way that they should be, and this is the way to do that. The last thing that I'll say, and then I'll turn it over to our partners at the City of Fairbanks, is right now, the legislation is in Senate Judiciary. The next stop is hopefully by the end of next week will be Senate Finance. If anyone is so inclined to take a look at the legislation and email their representative or senator in support and urging them to pass this legislation or not, hopefully it's the former, not the latter. I encourage it. And hopefully it'll get to the floor, and having that support with the full legislature will be critical as well. So with that, I would like to say thank you. If I have to jump off early, my apologies, but Katie Baldwin Johnson, our Chief Operating Officer, and Eric Willier, our Program Officer, are available to answer questions at the end. Thanks.
Great, thank you. I'll be bringing Mike and Brenda on.
Hi, everybody. Hello. We have some slides that Mike is going to start with.
All right, we'll bring your slide deck up.
I just started with the City of Fairbanks, but Mike is the person who got this all going and can kind of give a history of how that came about.
All right, Mike, go ahead.
Okay. All right. So I'm Mike Sanders. I am currently the Chief of Staff for the City of Fairbanks. Prior to that, though, I was the Housing and Homeless Coordinator and then the Crisis Now Coordinator. So back on Halloween of 2019, the trust came up and they wanted to talk about Crisis Now. Nobody knew what Crisis Now was before that, but you know, the thing that we did from the city's point of view is we're like, hey, let's have the meeting here. We'll have it in the council chambers, and we'll let people know that this is happening. What we weren't expecting was for that council chambers to be overfilling with people. We had, I don't even want to guess how many people we had. Our capacity in that room is, I think, 104, and it sure seemed like we were there. We had, you know, the trust came up, Eric Boyer came up, Katie Baldwin came up. They gave a great presentation. It really motivated the entire town, got people thinking about it. Then the next month, Recovery International came up, and this is November of 2019. RI International comes up and they talk to all the key players in town and really kind of planted that seed of hey, this isn't something that is just a good idea that's never going to come true. This is something that's happening. So then, you know, 2020 hit, things got slowed down a little bit, you know, just because of COVID and everything else that was going on in the world. And then in November of 2020, some of our key partners here in town said, hey, what about that mobile crisis team thing? Like, can we get that going? And they started looking at different grants. They looked at the Restore Hope grant from DBH, and the city agreed to go ahead and apply for that, and then you know, work with the Bridge to provide peer support specialists for a mobile crisis team, and to work with Alaska Behavioral Health to provide the clinicians for that mobile crisis team. So, you know, we started in November 2020, starting to look at that stuff. And then I think in probably January or February of 2021, you know, Eric came to me again, and he's like, at the time I was a housing and homeless coordinator, and you know, he pitched the idea of, hey, what do you think about doing the, you know, Crisis Now coordinator full time? And you know, I was all up for it. Talked to the mayor, talked to the city council. They all agreed that Crisis Now was the missing component in Fairbanks, and that we need to do what we could to get that program up and going. So I started transitioning my role over to Crisis Now full time. And during that time, the mobile crisis team was really starting to come together. They were hiring additional people. They were going through all sorts of training. In August 2021, they had the entire team hired, and they started a pretty comprehensive training program. During that time, we integrated them with the folks at dispatch so that they could be dispatched by our 911 dispatchers. We started integrating them with the fire department, with our paramedics, and with our law enforcement. So there were, for each of those, they spent about a month with each of the individuals. So that, like, the mobile crisis team would go with do ride-alongs with the police for a month, and then the other half of the mobile crisis team was with the fire department during that time, and they did a little switching. So by October of 2021, we were pretty sure that this mobile crisis team was as trained up as it could possibly be. We had all of the safety protocols in place. Our dispatchers were more than capable of giving them the same level of oversight that they give to all of the law enforcement and all of the paramedics and firefighters that we have. So we felt pretty comfortable with the mobile crisis team starting. For the first 2 weeks, they only did like co-response with other EMS So, they were going to calls with, paramedics, or they're going to calls with law enforcement. But after about 2 weeks, maybe 3 weeks, we decided to go ahead and go 24/7 with our mobile crisis team, being able to go either by themselves or with other folks. So then in January of 2022, tragedy struck the city. My boss at the time, the former chief of staff, unexpectedly passed away. Honestly, I knew as soon as it happened that I was probably going to be the person that was tagged for it, to fill in that spot. So I ended up taking the chief of staff spot. But the one thing that we all agreed upon was that we needed to find the right person to be the Crisis Now coordinator. And there was one person, I remember Travis Welch from the Trust asked me, when I was telling him, I was on the phone with him, telling him that I was going to accept the chief of staff position. And he asked me if there's anybody that I thought would be good. And I don't know why, but I was like, there's one person that I hope applies, Brenda McFarland. And but that's not to say Brenda didn't earn this position. We ended up putting the position out, and we had a ton of applicants. We ended up interviewing 10 of them. I'd say 8 of them could have done the job. Brenda just rose to the top of an incredible field. So in April of 2022, April 1st, Brenda started. And with that, Brenda is now the mobile crisis team expert. She is the Crisis Now expert. So I am going to turn it over to Brenda. And I have to apologize. I have to leave in about 15 minutes for another engagement. Take it away, Brenda.
Thank you so much. I just also wanted to express how I was definitely part of the core of people that felt the need for Crisis Now. I went to some of those first meetings, and it was kind of like, don't get your hopes up too much. Like, yeah, this will be awesome, but will this really happen for our community? And I had spent 7 years working in emergency shelter services, and also in short-term residential treatment programs. And so I had a real knowledge of like the gaps, and trying to get people a behavioral health appointment when I started was only possible if they were incarcerated or were able to get admitted into the hospital. And so as a case manager, and many of my fellow case managers in the community, we would spend a lot of our time going to the hospital with someone and waiting in the emergency room to try to help them be able to get admitted into the hospital and get that appointment. And then they would get that appointment that was like 3 weeks out, and it would be like circled on our calendar of, this is the date the person can't miss, and literally be, emailing and searching for the person that day to try to get them to the appointment. So I was very much in support of this program coming, and it's just been so wonderful to see what's already happened in Fairbanks. If you go back one slide, I can just give a little bit more detail about how the call center is working. So what is awesome is we have just a state-of-the-art emergency response center here in Fairbanks, and Christy Meredith is the director of that. And so she's worked really closely with this program to get this set up, and she's on all of the communication too, with 988 coming to fruition later this year, so that can be seamless as well. And so currently the dispatch can track the calls on their CAD that go to the mobile crisis team. They have told me that whereas before they would have to be with that caller back and forth with the law enforcement, maybe law enforcement was like, we weren't able to take them here, so we're sending it back. So they were continuing with the call, taking their time. Now once they route it to mobile crisis team, like the call is stacked, and they can move on to other calls and just see if there's anything that comes through from the team for any other requests. But it's a huge time relief for dispatch too. So I just don't want to forget that. When we're usually talking about the law enforcement officers, that's relieving the time. It's also relieving the dispatch team. They use the Freedom mobile app. And so with this, we're able to have really good data on en route time to calls, time on scene, how the calls are resolved, from being able to work with the emergency response center with these calls. And it's just amazing, their technology. And when we do switch to Caroline or in collaboration, we would do that when they had the same technology to be able to do the same process, because we love that these calls are there, like GPS located, and law enforcement could go directly to them if there was any issues. Then you can go to the next slide. So we talked a lot about the mobile crisis teams. I do want to say that I asked them, like, what's it like going at -40? I talked to Heather, one of the licensed clinicians, and she said, I sleep in my thermalwear, and then I just pull on my coveralls and I'm, out the door. And I was like, go Alaska, it is not a problem. -40, they go out, they're available at any time, 24/7. And they also just told me a week ago is they're also invested in the best care for the patients as well, that they're even offering some same day services now, not just next day appointments, if they can. And those, since the clinicians are with Alaska Behavioral Health, they're being offered through Alaska Behavioral Health, but they're also providing loss referrals to other places as well that may be more appropriate for the person, like Tanana Chiefs Conference. So fortunate, around the same time, they've brought on 4 new providers to see people. So that's really opening up that referral process as well. And you can go to the next slide. Okay. So Steve really went over this, so this is just part of that model of the stabilization after that place to go, and you can go on to the next slide. So in January, there has been a provider that has brought a place to go on to Fairbanks, where police can now have another place for to take people. For example, maybe they can't go back to the rescue mission, they're not in need of medical care, and so it's a place that people can relax and spend the night as well. So similar to that 23-hour model with crisis now. And then, as Mike discussed, there was a period there where they were looking for crisis now coordinator, and then now we have the position staffed fully again as of April 1st. Talked about Alaska Behavioral Health being able to offer same-day services. I just state that to say like how awesome that is for Fairbanks, but if your system like next day is fine, I think it's so much better than when it was 3 weeks, 4 weeks. I do not feel like this is something that you would have to have for this model to work. 81% of the mobile crisis team calls are now being diverted from law enforcement and from going to the hospital. And that's from the first quarter of data that we have from January to March. Of course, the first year, like your data is a little spotty because, it's not a full year yet. And so just looking at that quarter, and it was even higher the last quarter. So we're still, above the standards, and we're getting feedback, from the deputy chief of the police and everything, of how they're telling their officers, like, look, this is saving you a lot of time. Don't forget, like, if you do get called out to something and it turns into more of a behavioral health situation, because sometimes the dispatch doesn't get that right from the beginning of the call, that you can go ahead and call back to dispatch and ask for the mobile crisis team to come out. And so looking at the response time and the on-scene time for the calls that the law enforcement officers did not have to go to, it's about 133 hours saved in this first quarter. And that's about an average of 50 calls a month, which we expect will increase. Christy with the response center told me that people are already calling and asking for the mobile crisis team. So Fairbanks is small, word of mouth, and when people are being treated well and getting the more appropriate care, they're going to be spreading the word of that. And then, as I said, we're looking ahead to the 988 rollout as well. We haven't forgotten that. We're in those meetings and looking towards that. You can go to the next slide. So here's some data from that first quarter, January to March, 153 calls. And the mobile crisis teams, they're so motivated. They're like, we're going to get out and spread awareness about what we're doing. Like, they want more calls. And so that's exactly what you want to have. And so they're talking about going out to, retailers, apartment complexes, letting property managers know, like, this is our team, like, you can call and request for us. Instead of just having to be worried about calling 911 and the police coming out directly. And maybe that person has gotten really upset by that before. And so here's an alternative that you can request. They've had over 170 contacts in that quarter, 87 unique individuals, which I always think is an important number. If your communities start teams as well, I would say really track that number, so then you can kind of see, like, what is the recidivism of the calls in your continuum of care. And then the arrival to the scene, this is like decreased every month that we've had the teams going out. And so it's 27 minutes, 56 seconds. Standards that I've read is that it'd be like less than an hour. So, we're less than a half hour now. This includes the mental health clinician going, picking up the peer support specialist, and then going to the patient. And then they spend about 40 minutes average on scene with the patient. You can go to the next slide. So this is something people are usually pretty interested in. And I was also very interested in when I started, because my first question is like, isn't this dangerous? When I heard Mike was doing this, I was like, what? You're doing this? That's really dangerous. What are you putting in place? I'm like a real, how is this gonna work? What are the precautions? So they came up with response levels for the calls. 2 people always go to the call, no matter what. But the actually, like, level 5, sorry, if it's in a secure facility with other staff there, then 1 person can go. But level 1 is the law enforcement going first, and this would be, some pretty urgent, emergent reasons for that. Maybe the person has a weapon on them. Maybe the dispatch can see that there's been other suicide attempts or something. So this would be law enforcement only going in, and MCT waiting to even see, and then the law enforcement might take that whole call. The MCT might not be called in at all. And then it goes down from that. With level 2, the law enforcement isn't taking any other calls. They're staging for the whole time near the scene, and then down level 3, level 4, level 5. And so Christy, again, from the Emergency Response Center, helped come up with these levels. And so this is something we would really want any crisis call center, in Fairbanks that would take these calls to also use, so we can all be using the same language. Mobile crisis teams are used to it, and I would really recommend it for the whole state because it's working really well. And then you can also get data on what were kind of the levels of the calls coming through. You can go to the next slide. Okay, so outcomes of the call, I mentioned the 81%. We included 4 patients that were transported to that new stabilization center that I mentioned during that quarter. And then 15% were taken to the hospital, and then 4% required law enforcement intervention. Okay, next slide. Okay, so outcomes. So the peer support specialists do a lot of the follow-up as well. And so they've been able to have, with that 87 individuals, actually 62 interactions. So that's really good post-crisis. One of the things they mentioned, sometimes people just, don't want to talk after that. And so I think the 62 is a really good number for that. They've made 149 referrals. And then you have the percentages of, some of the higher categories that they're making referrals for. One of the things that they've mentioned too is just, this is how we come up with what's the next gap, in our community, is that the success of the engagement of the mental health services has been higher than the last quarter, but the success of the substance use and recovery services has been lower. They weren't able to find as many places that could do a full assessment with the person, wait lists, that kind of thing. And so then, we can develop out of this, it sounds like we need more places that can do assessments, or we need more places that have a variety of recovery services. And we're referring to the bridge, but it's going to be True North Recovery. I don't think they've done the official name change, but they're in the Valley and they have a lot of recovery services. So that's really promising, and that the bridge is going under them. And I think they have wonderful plans for more recovery services in Fairbanks. You can go to the next slide. And so then this is our website here. Mike put a lot of articles on there of just all the research, all the studies for Crisis Now, and then we update the data on here. So this is a great place to go if you need more information. And then I'll put my email in the chat as well, and I think they'll have a question time at the end as well.
Thanks, everybody.
Hey, thank you. All right, we'll bring on Renee and Melissa.
Good morning, everybody.
To start and say good morning. Thank you for having us. We're really excited to present today about some of the coalition work we've been doing here in Anchorage. I'm really grateful for all the partnerships on the call. So I think our plan this morning is Renee and I are going to kind of tag team these slides and share a little bit of information around the work we've been doing as a partnership together. And then Renee will dive into a little bit more around the specific aspects of crisis stabilization programs that both Southcentral Foundation and Providence are intending to operate. And then I'll end by talking a little bit about what we're hoping to accomplish at Southcentral Foundation on the ANMC campus. If you can go to the next slide, that'd be great. Thank you. So we wanted to just kind of frame the work that we've been doing by starting with, in around 2018, leadership at Providence Southcentral Foundation and the Alaska Mental Health Trust Authority formed what we were calling a coalition. We banded together to really say we need to address this work and really be intentional around how we walk forward in the Anchorage area, but also the larger community, and really wanted to have that collective learning. In doing that, we started by meeting with stakeholders around the community, generating a little bit of a gap analysis or kind of needs assessment to understand what were the needs here in Anchorage. Through that work, both Southcentral Foundation and Providence applied for funding through the Mental Health Trust Authority and were awarded last year to help our planning efforts for our stabilization programs. We've also leveraged the partnership with Recovery Innovations International to really learn from the work that they've been doing across the country and to help build our learning. We both are committed to expanding the crisis continuum, building out these services, and continuing to propose new funding. These services are challenging to kind of stand up. They're very complex. They also require a lot of capital and infrastructure. So really looking at what are the best ways that we can fund these programs and get them up and running.
I think the component
Yeah.
of this coalition, the trust was already leading the way with evaluating best practice, and the opportunity for Southcentral Foundation or Providence to try to address this need individually was there. We could have done that. We could have tried to work as we have before to address the needs as individual providers within the organization that we are in. But we decided that really transformational change comes when the community comes together and looks at the system of care. And so you think in terms of 2018 and where we are now, I know it's a lot of work in that 4 years and certainly in the middle of a pandemic, but the passion, I think that all of the community stakeholders in Anchorage, but also throughout the state, like you've heard from Fairbanks, is there because the need is so significant. And we recognize that siloed strategic planning is not where we really can transform care and take care of our communities differently and spend money in places where we're going to have good outcomes.
Thank you, Renee. I was just thinking as you were talking, I think the other really important component of our coalition is both Southcentral and Providence, and then of course, our community providers all have different experience operating different aspects of the continuum as it is today. And so really learning from each other around best practices, what's been working, what's not working, and really uniting that passion across the community has been a huge part, and just really rewarding work to be a part of as well. Next slide, please. So with this kind of building on that, with this partnership in action, really understanding these new service lines, community programs did generate that need for shared learning and decision making. So we were fortunate enough to continue our work with the trust and then partnership with AgNewBek to really analyze the local data. What were we seeing in our local emergency rooms? What were we seeing across our behavioral health systems? Looking at financial modeling and sustainability. We spent hours looking at financial modeling and sustainability to really understand provider types. What were the various reimbursement scenarios that would be helpful and necessary with the 1115 waiver, as well as with different opportunities. Have done a lot of review of regulations, local or legal considerations, looking at licensing standards. As we've mentioned, the legislation moving through will help support these programs because current programs are able to support in a certain way, but the licensing, accreditation, and regulatory framework is really necessary to carry out the Crisis Now continuum as a whole. So our hope is that the work that we've done will help other communities and organizations pick off where we've left off and really be able to kind of create a path forward for themselves. Next slide, please. So a huge part of our work has really been looking at clinical models. And so some of our initial work was really doing a broad search, both from the learning that the Trust has done, but also looking at other programs across the country. What are best practices within crisis stabilization centers? So you have the Crisis Now framework, and then you have the clinical aspect of these crisis stabilization centers. So we were able to be awarded a small grant early on in about 2019, 2020, and completed a few site visits. The pandemic really slowed these site visits, but we've since been able to pick them up and look at different programs across the country. And these are programs operating in different states that have and have not implemented an 1115 waiver to support Crisis Now or various aspects of crisis legislation. And our goal in doing this has really been landing on an evidence-informed clinical model that creates this community solution and is really providing the best clinical quality care that our community can have. And Providence and South Central really want to operate similar models so that the community experience is similar for both organizations, that we're not operating in silos. We're really partnering in that together for that clinical community solution. Next slide, please. So I'll let Renee talk through this slide, just some of our stakeholders, both internally at Providence, externally, and then in the larger community.
I think it's just important to call out that internally engaging the larger systems of care and really making sure they understand how this model is different, that it's not the medical model, but it's a community behavioral health lens and really providing expert behavioral health treatment at the point of the crisis. And so we've been engaging, different leaders within our system in behavioral health, but also in the emergency room, and our medical directors, so that they understand this form of care, and then continuing to engage other providers as well outside of the care in terms of the Alaska Behavioral Health, other peer support, and then our partnership with the trust has been essential to moving this work forward, as well as looking at how do we include our emergency systems early so that we build a partnership that is ready to do the work together, but also capture data and process improvement over time. And so we're pretty proud of the opportunities we've taken to really expand our coalition and bring in others into the conversation and we plan to do that even more so in the next few years. Next slide. So we want to talk about Providence's effort and commitment to a crisis stabilization center. And we're really excited. We'll go to the next slide. We're very excited to look at our opportunity to focus really uniquely on crisis. And I'm just showing the slide. This is from a consultant, SG2, their analysis of where behavioral health is growing. And you can see really through the slide that in all of the areas, there's opportunity for strategic planning and growth, and that we focus specifically on using our planning to partner in collaboration with the community and to really address some of the challenges that we're facing in Anchorage, but really also throughout the state with behavioral health, because we know the impact to API grows as the Anchorage need grows. And so the opportunity to address crisis in care in Alaska is in Anchorage and will be through crisis. Next slide. When we look at a stabilization center, we're really talking about the 23 and 24-hour care. These terms, 23-hour crisis stabilization and short-term crisis residential, are from our 1115 waiver, but they really correlate with what Steve already described. And the 23-hour, this is a place where people can go with no wrong door for either substance use or mental health crises, and they can stay, an hour all the way up to 23 hours to provide that stabilization for withdrawal, to get medications for psychiatric crises, and there's opportunity for follow-up care. Most of the time in Anchorage, you leave a emergency room center, and it depends on where you are, whether or not you get follow-up care. And so we wanted to, both South Central and Providence, want to expand the opportunity for a behavioral health crisis to be treated effectively within this 23-hour, but then also follow up and linkage to community behavioral health services or services within tribal entities as well. And so there's an opportunity for people to get stabilized within this 23-hour, but then if not, they can move into a short-term crisis residential program to get that stabilization, from 3 to 7 days, or maybe they need a longer term program and need to go to MATSU and go to a detention evaluation treatment center if they're involuntary. And like Steve talked about, both of these settings really need to be involuntary and voluntary, so that we can serve people in crisis and they don't have to go to the emergency room or to jail because they're in such acute crisis. I can give you a short example of this that I think just speaks to the importance and the need. I have had many parents call me in distress of their 20-something child going through their first psychotic break or substance use psychosis, and they are going in and out of the emergency room multiple times with not necessarily receiving any care related to their crisis. And when parents reach out, I will often talk with them. And in one instance, I can remember a family so desperately saying, is this really the standard of care? Do people feel proud of the fact that my child is going in and out of this care? And because he, is not wanting to get care, he's not getting care and he's dying. And ultimately, we were able to support this person in getting to a detention and evaluation treatment program, but it was not without multiple instances of trying to engage in care and with a lot of heartache. And potentially that young man could have died. And so when we think about the opportunity to expand this type of care, it needs to be involuntary so that when someone really is in a psychotic episode, also with substance use, because oftentimes you can be turned down if you have, one or the other and you don't fit into that program. This program allows for both substance use and psychosis or psychiatric crisis at the same time. And we're building this through the 1115 waiver, which is also really important in expanding community behavioral health services. Next slide. So we want to think about this as goals in expanding care, certainly for the adult population. That's who we plan to serve in our stabilization center. And when I talked about this earlier, that we'll be reducing the burden on API just due to the fact that we'll have increased access in Anchorage, and hopefully that will allow for API to take admissions from all over the state, and then the opportunity to really partner with law enforcement and first responders so that they are able to bring community members to us and quickly provide that handoff, and evidence-based care will be there immediately for that person that is struggling with behavioral health crisis. We certainly plan to work with DHSS and looking at the overall gaps in the system with this crisis stabilization center, and it helps to fulfill their goals as well. And I've talked about the no wrong door, really ensuring that they have that opportunity to be linked to other types of care and discharge planning. So you can see that there's an incredible amount of care that will be offered within the center based on the volumes. Next slide. These are some of the performance metrics. I won't go into those, but I think you can see right here that there are already so many metrics out there allowing for us to really measure what is best practice, how, and we won't be able to get there right away. We're going to need some time to build up the ability to be a no wrong door, to provide the level of care that we'd like to get to in terms of the volume. But we feel really fortunate to partner with RI and with Southcentral Foundation, and we have a footprint of providing psychiatric emergency services for many years successfully, and we plan to use that to really ensure that there's safe, client-centered, trauma-informed care, and that the partnerships with our community partners will be evaluated regularly. Next slide. Here we see that we're planning on opening 12 chairs and 12 beds, and that you can see the estimated treatment episodes and the volume. And the average length of stay we're estimating would be right around that 21 hours, but also have that short-term stabilization at 4 days. So we start off imagining that the occupancy will be around 85 to 90% in both of the programs, and we're hopeful that that really we can meet the need alongside Southcentral with their plans as well. And this will be, we're not sure if that will need more, but we're definitely feel like this is an important expansion. Next slide. So we've got a multidisciplinary team with nurse practitioners, therapists, peer support. We've got the opportunity to really bring people who have lived experience into the stabilization centers and have them be part of the team to show hope that their transformation is possible, alongside other team members that provide the clinical care too. I think they're equally important within this clinical model and unique to a community behavioral health setting, that we really value providing that opportunity, and then capacity to accept all referrals at least 90% of the time is that no wrong door approach. And then we will have opportunity for walk-in as well. And there will be opportunity to assess physical needs, but our primary focus will be on the behavioral health crisis. Next slide. This slide just really talks about the importance of the staffing model. I talked a little bit about that already. I'll call out here that workforce is going to be a real challenge with this. We're really concerned around needing, to expand our education programs to ensure that we have psychiatric nursing, therapists, nurse practitioners, physicians, all within the behavioral health footprint are needed. And we want to partner with communities to continue to look at workforce challenges. They're very, very important in this clinical model that we have the staff to open, and we'd like to be able to open in July of 2023. And so we're going to need to continue to plan together on how we're going to address this need for both Southcentral Foundation, for the crisis mobile team development, for the 23 and 24-hour. Next slide. Regulation and accreditation, as Michelle said, or Melissa said, we have a lot of work to do still around this. There's not the footprint. We need the legislation to go through. We have a great partnership with DHSS and DBH, Department of Behavioral Health, that we're working towards. How do we make this happen so that we can have these programs available soon? And I think it goes to show you how long we've been planning and the importance of building this continuum together with all the stakeholders, including government. Next slide. We are also evaluating a behavioral health urgent care for crises for behavioral health that maybe will not meet that same level that the 24-hour would need. Somebody might be able to come into an urgent care, get some brief intervention and some support in safety planning or medication management, and wouldn't need the resources that are really embedded in that 23-hour care of stabilization. They're maybe withdrawal is ambulatory. They don't need that supervision of a nurse or a nurse practitioner or a clinician to be over a longer period. They could come in and get the benefits of a short visit. That's where this urgent care would come in. And we're looking at being able to provide peer support within this program as well. And it'll also be an opportunity for people if they're struggling to provide a provider, which we know in all throughout the state of Alaska, providers are very challenging to find for either immediate crisis for somebody that's in therapy, but maybe just needs that safety planning because they're having extreme, just suicidal ideation and thoughts, but they're willing to safety plan and they can be safer and be monitored in their home. This is where the urgent care would come in, and we would then also provide discharge planning and referral to community sources. So people can kind of have a one step lower before that 23-hour care. Next slide. So I think we've gone over this about the benefits. I just want to say that Providence is committed to providing care for the most vulnerable. That is embedded in our mission. And we see behavioral crisis as being incredibly important for to care for those in terms of our community needs this resource. We know that we don't have enough of it, and we know that it's causing an impact to our community members to not be able to receive those services. People are getting sicker, not better, even when they do get some type of emergent care. So we're excited to be part of this collaboration, and then to prevent people from being in the jail system or from worsening in their condition. And you can see that the cost of care, we want to target that. Part of the strategic planning is moving away from the hospital most acute care into a behavioral health setting. I think the challenges, like you talked about the workforce and the access to more behavioral health services for case management and ACT teams, which are community teams that can go out and provide services for serious persistent mental illness and severe substance use. We know that needs to be built up as well, and we're excited to partner with other organizations like Alaska Behavioral Health and Choices, those programs that are really able to provide ongoing care after the acute crisis. Melissa, I don't know if you want to add anything to this.
No, I think that's the component of continuing to build out the entire continuum is just a huge challenge with workforce as well. And it's very needed to make the whole system work robustly together. So the community-based services are equally as important to the crisis stabilization. And one of the challenges we faced is which part of the continuum do you build out first? And we've all sat in that and struggled with that and really said, we can't build it all out at once. So we need to start with what are our major pinch points right now? And crisis stabilization centers are those major pinch points, trying to move away from that ED experience and most appropriately match the best location and intervention for where people need it right then and there.
We don't have a lot more time. Next slide.
Yep. So I think this is our last one. So thank you, Renee, for kind of sharing a little bit about the clinical model. So the staffing, the types of services that Renee shared would be very similar to what we intend to build out here on the Alaska Native Medical Center. So Southcentral has been partnering with ANTHC, and both of our boards are really committed to expanding crisis services on the ANMC campus. We've had a lot of conversations around the best location and have landed for our system. Customer owners come to our campus for care. And so we are committed to expanding services. We also really have sat in the need for a statewide solution as well for our larger tribal health system. So at present, we have a very busy emergency department, like most emergency departments, and are seeing incredibly high volumes of mental health and crisis. We have an embedded behavioral health team right now that's able to meet the needs. But our first effort is really building out that crisis stabilization center, that 23-hour center. So we've identified a space on the ANMC campus. It is a federal property. I say this for context because it's slowing us down a little bit more than we'd like in terms of getting our approvals, but we are committed to this space for 23-hour stabilization for adults. Parallel to that, we are also committed to and exploring additional space on this campus or nearby for adult crisis residential, as well as wanting to explore the needs for youth crisis. We recognize throughout this project, we've been talking about adults, but we have a huge gap in our crisis services for youth as well. So our plan is a 23-hour crisis stabilization center on this campus with 12 chairs, very similar to Providence's program, and with the goal of being able to expand that while building the crisis residential. So our hope is that we would be operating within a year and a half, but these things take time. So we're going to continue to move forward and work on expansion. So I think that that is it for us, and really leave time for questions. Thank you all for your time.
Great, thank you so much, Melissa and Renee. I'm going to bring in our other speakers and Ralph. And if you can turn on your cameras, those of you that So Ralph, if you had maybe an initial question that you wanted to ask.
Hopefully I can slip in two questions, Meredith.
Go ahead.
Yes, Steve opened with the comment that was an effort to transform the system. And I think it's important. I think we all appreciate that the word transform doesn't mean completely change. It means integrate into a large existing system. And Commonwealth North has, as part of this project, is going to hire a contractor to develop a short report on chronic disease management, which gets into this integrating the whole system. So I had a specific question for Melissa, because you really touched on, you said in this planning, the issue of funding models, licensing, regulation, really gets onto how this piece of the system fits in with the broader system. And it's just a simple question, Melissa. Is there a report or something that you put together that we could come back to you and say that could provide that information about the kinds of issues? Because I know there are many technical issues, and I don't want to get into them here. But it's just can we contact you as follow up on this? Would be a quick question.
The short answer is yes. I think any of us with the Trust, Providence, Alaska, even our Fairbanks partners could provide some information on that. Absolutely.
So my second question was about, again, the focus of this series is on chronic disease management. It's a large, we're building onto what's already a large, complex system. Whether it's doing a great job or not is perhaps a different issue, but it's already a large system that has pieces that have tried to address some of these issues in the past. I'll just pick one because I happened to bump into the idea that Medicaid had a navigator program at some point to deal with some of its members. One of our previous speakers, I believe it was an emergency room person, said, well, I've never even heard of that. And that's kind of my question, to what extent have we tried these things in the past and the pieces have stayed separate? How are we pulling those pieces together now? I know that's a bit of an ambiguous question, but perhaps I can give it as a place to start. Thank you.
So Ralph, was that for the trust? Oh, you're on mute again, Ralph.
Yes, why don't we start with the trust?
So I've just for the audience's information, Steve had to leave, so we've been joined by Katie Baldwin Johnson and Eric Boyer, and if one of you might want to address that question.
And my internet appears to have glitched a little bit, so I might have missed the question, Ralph. Eric, did you catch the question?
Yeah. Hey, Katie, thanks. Eric Boyer with the Trust. Great question, Ralph. Part of the mission of the Trust is advocacy and education. And so part of the whole process of rolling out Crisis Now has been community education so that knowledge of current best practices and systems of care within like Medicaid aren't lost. And we're such a large geographic state that it takes a lot of effort and work and partnership with folks like at Southcentral Foundation and Providence, City of Fairbanks, to be able to get out at the community level and do forums just like this one, but also with professionals, with our university system, within our departments of the state of Alaska. Turnover, workforce, Renee and Melissa mentioned that, their issues. As soon as a position turns over, that knowledge could be lost. And so that's why we have to keep digging in and making sure that people know what the systems have to provide and offer, and that institutional knowledge isn't lost. Anything the rest of you might add to that?
I think I would just add is the idea of a navigator is a really important one. And it also speaks to systems are so complex that customer owners need a navigator. So I think Eric's point is really valid, which is being able to really broadly educate the community and design a system that isn't that complicated so that a navigator could be supportive rather than a crucial essential role. I think it's a balancing act of, we need to design systems that are easy to use while also leveraging, helping people navigate what they might not know.
Thank you.
I would just add, if also like some of those services were reliant on the person having a smartphone to download an app, having data on their phone, at least, with the homeless population, that wasn't always possible. So they might have gotten like one phone call, but not been able to call back to the person. And so I think with these mobile crisis teams going out in person and saying, I can actually transport you to the place where you can receive more care, like there's that connect now that maybe, a navigator calling the phone just wasn't able to have if they weren't like located in that city.
Okay, all right, thank you, everyone. Just again, there's some good information being shared in the chat, so just refer the audience to review the chat content as well. Marge Stone King with AARP is with us, and she's asking about how those who might be experiencing dementias might intersect with this system. And I will add that since our focus is on chronic disease and how to, improve care and alleviate some of the high cost services, we also heard, and I think some of maybe Brenda's data might support that once the system is in place, that there may be an incidence of high utilization by a small population. And so how do we address that head on as well?
I can start off by just talking about, I know I'll start, I believe mostly you can add to this, but I think we're both focused on being that no wrong door, and that dementia is a part of the continuum of care that is a part of the continuum of diseases that really touch behavioral health often, and that we want to be able to continue to provide those services. We know that there are services that are specific to dementia that are really, really important for chronic disease management. And we think that we can partner well with those other community programs. But absolutely, we see that that's a challenge within our community right now for housing and for some ongoing treatment. And so, but behavioral health needs to be a part of that. We absolutely are already, and we see these programs as being a part of that and able to treat that as well.
Hey,
The other thing,
go ahead, Melissa.
I was going to say, the only other thing I would add is that part of the stabilization programs do include a component of discharge and case management. So part of what I'm thinking is this idea that caregiver support is huge when it comes to dementia. And so if an individual with dementia comes to one of the stabilization centers, we would want to support that follow-up with a phone call and make sure that we're helping bridge connections. And maybe that's for the individual experiencing dementia, or it's for the caregiver unit around them, because that is an important component, is that follow-up and making sure people's needs were met, and what can we do after to support.
Yeah, this is Eric. Thanks, Melissa and Renee. That's awesome. You know, this system will provide that triage support for Marge's question. But what Melissa was talking to is really equipping the community. And, you know, the Trust, Southcentral Foundation, Providence, we partner with Alzheimer's Resources of Alaska. We partner with the university system to provide echo clinics, which is a spoken hub way to provide expertise out to communities so that those skill sets are in the community where that person is, you know, lives in the origin, so that they can remain there with that community-based care and discharge planning. All those kind of fit together. And so it's being able to really knit those together to provide that level of care that really supports a family that's learning about that.
A quick question about workforce. Certainly, one of the, I guess I see it as somewhat ironic coming out of this pandemic, is that workforce has become such a critical issue across so many industries. And you've identified for us that that will be the case in implementing this continuum of care. Are there particular occupations, and I'm really thinking that it's probably in the the technician or the diagnostician, the sort of entry level type occupations that you see as most critical, and then also related to that is, do we have the training system and the pipeline in place to get those people into the workforce here in Alaska?
Well, I could start, and then I know the Trust is working really hard on this too, and Southcentral Foundation. I would say all the positions are really challenged and equally important. I see peer support being as important in this effort as is a nurse practitioner, psychiatric nursing. All of those pipelines, I think, need to be built up so that we do not suffer as one person transitions into a new role. And the ability for us to see education as a key component to any of the changes that we make, and how do we partner the opportunity that we have to grow the social work department in UAA, I think there's efforts there, and we can I know Eric and Katie can speak to those. I think that's key. We need also licensed professional counselors. We need psychiatrists. We need a psychiatric residency, which Providence and I know is we are very passionate about trying to lift a psychiatric residency program right now and doing planning to do that, and would love partners in that process. So I think it's pretty much every discipline within the component of behavioral health care that is needed.
Anyone else?
Agree. It's broadly across the board. And I think we have this nice problem of expanding all this behavioral health and this workforce challenge that we're sitting in. People are making different choices in employment during and after the pandemic. And so I think, Juanetta, you asked about the training. We do have wonderful training programs in our state. It's a question of also encouraging people to go into the field of mental health and, how we pay our mental health providers. And then there's this aspect of documentation burden, which mental health struggles with in a way that is unique to our field.
And this, Eric, and I would just add, great discussion. Kathy Giesel's on and made a comment about workforce being a huge thing, and she would know, she's, a medical practitioner herself. We're working to expand those programs. We have a public-private partnership, a healthcare workforce coalition. We meet monthly, university, the trade associations, the state, and we're working together to really dig into that and try to do that. Plus market to the lower 48, because we need help more than what we can produce in state. And oh, great. Brenda answered Marge's question in the chat. So I was going to do that, but thank you, Brenda. Perfect.
Yeah, again, refer folks to the chat for some additional clarification and information that's coming forward. One point of curiosity, obviously there's a lot of public communication going on about the Crisis Now model right now. And I'm just curious, I mean, obviously there's pending legislation, and so some of that communication must be aimed at convincing leaders about what's necessary, but also just broadening public awareness and information about the Crisis Now model and responding to behavioral health crises. I'm just curious as to whether your visits to Maricopa and listening to other jurisdictions that have been implementing the Crisis Now model, what role does that public education play? And I'm particularly struck by the 988. That's going to be a significant behavioral change for the general public to not dial 911 right away.
So I can start on this if you guys are okay. So, the trust is working with our partners at the community level in the state to really push out media about this. Allison Biastock, who is our chief information officer, is on the call. She worked really hard with ADN to do paid media outreach. And I think we did a series of 6 articles over the last year that really start educating the community from a beneficiary up into services and what's to come. We also have paid advertising on 2 TV stations that have been broadcasting. And then we're also working with stakeholders to reach out through their networks, through their trade associations to get the messaging out. And, Allison's working with the state of Alaska Information Office to really planfully look at how 988 will be marketed and how will that information go out in the next year. So all very important, and it'll be a continual process. That's public health in action, is to continually educate the community, just like we do around 911, wearing a seatbelt. You think about all the things we've grown up with. It's a continual process, and that's what will happen with behavioral health in 988.
Great. Well, we are right at 9:30. I'm going to go back to Ralph and just thank our panelists and audience. And Ralph, any closing remarks?
Well, I certainly wanted to thank Providence and Southcentral and Fairbanks for joining us today and explaining the programs that are going on. I guess I'd like to also close by thanking the trust. As the comments just mentioned, this is a long-term effort, and telling the public that we can't solve it in 2 years is not an easy answer to deliver. And I appreciate and I think many of us here appreciate the role of the trust for making that upfront investment to get some things going, but also making a long-term commitment to get us through what will be some inevitable rough spots, I'm sure. So thanks very much to the trust, and thanks everybody for joining us.